Good morning, everyone. My name is Mérida Kawoq. Today I'm representing we reason Wuqu, and we are located in Guatemala, and our central is in Chipantenango. For us, it's a pleasure to be here in this first Congress. We would like to tell you that we are organization, a nonprofit organization, and we unite language, culture, and science with the Mayan community in Guatemala. Us as Kawoq, with people, doesn't matter where they're were born or the language that they speak, and they will have more the highest quality. And we also offer integral services to our people and wherever they feel more comfortable speaking. Our areas of programs include nutrition, infant nutrition, women's health, chronic illnesses. Also, our service, we present them in different departments, mention them like Chibantenango, Zapagatepeque, Quesatenango, Xusitepeque, Chique, and we are in other programs in Guatapanango, San Marcos, Santa de la Paz, y Cutiapa. Next. Um, this image, we could observe that it's that we have the nutrition program in the first infancy. Our organization is leader in this field of development and nutrition in the first infancy. We work with babies and their families in the areas that we have incidents. Next. The program maternal health. This program, we are expert in the use of technology, smartphones to help all parts to detect complications in pregnancy and to help patients and transfer them to the hospitals when they have problems that need advanced medical attention. Also, we have women's health, where we offer women's health to thousands of to women, and we also help with natality control. We also, especially, we are trained in diagnostic and trained in CA cervix, which is one of the principal things of death in Guatemala. Also, among our programs of navigation, we have attention to chronic illnesses. We are revolutionizing this in the rural area, and our focus is in chronic illness treatment and integral in clinics, and the sensibility in linguistic and cultural. And also we work a long term with the families, patient and their families. And we also invest in the training of nurses and community health workers. We have had excellent and patients like that we started in 2010, and this important step, because we do not stop after anything, because like that people could get the attention that they deserve. We are innovative in this type of attention for patients who with complex illnesses in rural areas of Guatemala. This would allow us to treat effectively, and I could mention some like cardiomyopathy, metabolic in renal in illnesses, advanced cancer, among others. Our team of navigators, they speak Maya language, and they help with taking down the barriers with our indigenous patients in patient navigation. Like we have spoken regarding the barriers, that is the linguistic in Guatemala. we are a country that is rich, and we have different Mayan languages. With 22 different languages, it's a very big barrier. As an organization, we look for allies among other organizations to so we could do translations in other languages that probably we do not handle. Um, we could speak in different languages in different regions. Among we have two people who have received the course of patient navigation of NPI, and they have had that certification with a duration of 8 months. I have been one of the persons, and as you could have heard, I have had a navigator approximately for 8 years. I've been, and I had the pleasure of having the certification with NPI. And we have a coworker among the organization that have obtained this certification, where they have been able to we've been able to meet doctors that we have helped, and it's a big um web, and there's a lot of people that have joined this training, and it has been very gratifying knowing that we're not alone, and that we can count on this network of support. And this it's important to have this certification like that, because having the training by doctors, because sometimes we believe that we have enough information, but each day there are days that we could learn new things. I was talking to you about the patient navigation. Also, this has reduced the maternal death and has grown the amount of women that are receiving services at the hospitals. This is very interesting data. The more common thing in the indigenous is that where we have incidents, we could mention the cervix cancer, cervix, breast, prostate, colon, liver cancer. We can focus in navigation, probably talking a little bit in relation of what is mean a day in a navigator's life through the health care system. Usually, the work day of a navigator starts since 3:30 a.m., where the navigator coordinates with the pilot of the association to transfer the patient to the hospitals in the capital city, and they go to different medical appointments at different places, like Hospital Roosevelt, so Hospital San Juan de Dios, or the National League Against Cancer. And as we know, these appointments, they give you numbers or and give appointments at 6 a.m. or 7 a.m. And that's why the navigator leaves. That's why the navigator starts so early. The navigator starts doing all the things that he needs to do the lines, pay for the consultation in some places, and the patient, like that, the patient could receive the medical services. The patient goes in with the navigator to the medical consultation to support, and want some cases with translation, with interpretation, because our patients, like I said, sometimes, like I said, they speak Huachiquel or Chichen in some other cases, and like that, the patient could solve any doubts with he has with the doctors, and he can have all the information, all the adequate information at the end of the consultation. The navigator always speaks with the patient to answer any doubts that the patient has, and the navigator then proceeds to do the next medical consultation appointments, to do for testing and whatever the doctor have requested. Once they have established the appointments, the navigator um, transfer the patient to their place of origin. Like that, the navigator does not go with one patient. Sometimes he is taking 3 or 4 patients in different centers and finalizing his activity around 3 or 4 in the afternoon from the capital city to return to the place of residence. This is that is probably a long day in the navigator when we offer these services. Um, Challenges that we have confronted and that our population confronts is to look for medical regarding medical care. We could mention the discrimination, language barrier, that is another barrier, not knowing the place, and also transportation and fear of not knowing the place and not enough economic resources. This is another one of the barriers. The organization tries to support patients, especially through navigation, with the support of navigators, that is translation, doing whatever they need to do that I mentioned, and also to support with transportation to, in some cases, we pay for the testing, for lab work, etc., among others. Also, in some cases, we pay for the treatment. For example, radiotherapy, chemotherapy, surgeries. In some other cases, we cover medications, and also we support with follow-up appointment through medical follow-ups through 3 different centers. We always do a socioeconomic study to establish in which areas the patient needs support. Generally, the patient, that is the amount of patients that we navigate each year in different problems in the capital city are approximately 90 patients. Always thinking the always keeping in mind that at minimum 3 visits and maximum 15 or more in the each center per patient. Also, we navigate patients in maternal health that are approximately, we could talk about to 200 to 300 patients. It's the information we have as Kawoq. We could present it to you, and like that, you would know what we do, and you could yeah, this is a big job that we are realizing that we're doing, and it would be excellent that these services and this support could be applied within the whole country through more organizations. Thank you very much for all of you for paying attention, and that. Good morning. I'm Dr. Esther Ri, the medical director of Centro de Mama, the Brigham and Women Hospital, and surgeon of Dana-Farber Cancer Institute in the United States. I would like to thank Nancy Peña and the committee to invite me to speak regarding this this patient navigation and communities indigenous with a high risk of cancer. Breast cancer is the second diagnosis, most frequent diagnosis after skin cancer, and the second cause of death in women after lung cancer. Over 200,000 new cases of breast cancer, invasive cancer, are diagnosed in the United States every year. In my practice, approximately 10% are Hispanics. we estimate that 17,000 Hispanics are diagnosed with breast cancer every year. Even though that Hispanics have less probabilities to be diagnosed with breast cancer than white or African Americans. The breast cancer is the type of diagnostic more frequent and in the biggest case of death in Hispanic women. To Hispanic women, it is diagnosed more frequently in posterior and with negative prognostic, with bigger tumors of bigger size and higher grades. The reason of disparities in the presentation of the results of cancer in general, access and utilization of medical attention, less access to specialized care, less low rate of protection, and we do not have a specific attention. So institutional structure of the place of living, composition, disponibility of diet, exercise, smoke, education, and genetic material, genetic ascendance of the germinal line, changes epigenetics, microbiome, biology, tumor biology that is more aggressive, like the cancer, breast cancer, triple negative, estrogenous, progesterone receptor, and HER2 negative. Disparities of cancer in general. It's more frequent, superior diagnostic, more the economical, more morbidity, and more death. Patient navigator has very big pressure at our practice. It eliminates the barriers of the patient to identify and helping them to navigate through the services and the medical system. They build solid relationships to help patients to keep his compromise with his medical care and to keep up with medications and treatments. They get in touch with the medical equipment to facilitate the services. Breast cancer can be curable. In general, Hispanic women have the same overall survival as non-Hispanic women. Early detection and adherence to care and are key to a cure. For a cure. Understanding the barriers and helping to overcome those barriers is made possible by our patient navigators. Patient navigators save lives. Thank you.
Thank you very much for the invitation to present at NPI. It is my pleasure to present my work with Nancy Pena over the last 15 years at the Brigham and Women's Hospital, Dana-Farber Cancer Center in Boston. I'm the medical director of the Gynecologic Oncology Clinic at the Brigham and Women's Hospital, and Nancy and I have been working together on navigating patients to best practices and to care in our colposcopy clinic over the past 15 years. So the title of our talk today is The Impact of Patient Navigation in Hispanic Communities in the United States, Reducing Barriers to Improve Access to Cancer Detection, specifically of the cervix. Next slide, please. The objectives of our talk today will be to summarize our patient navigation program at the Dana-Farber Brigham and Women's Cancer Center. Of note, I should say that the Brigham and Women's Hospital and Dana-Farber Cancer Center are joined. They have a bridge that attaches both hospitals, and so we work as sort of one practice for this purpose. We're going to talk today about barriers that affect specifically Hispanic communities in the United States and Massachusetts. We're going to summarize the evidence-based interventions that we've used to reduce barriers and to improve access for HPV and cervical cancer detection. And we'd like to talk about lessons learned. Next slide, please. To start, let me give you some context. Cervical cancer is diagnosed more frequently due to a lack of appropriate screening, specifically Pap tests or HPV tests. And then once a screen is abnormal, a lack of appropriate follow-up in order to get a biopsy and diagnosis of a precancer and subsequently preventive treatment so that the precancer does not develop into cancer. Women in minority communities in the United States have low rates of follow-up for colposcopy and also low rates of tests after abnormal Pap tests. Our colposcopy clinic brings help to these women, and we specifically look at or evaluate and take care of patients who have abnormal Paps or in other ways have altered risk of cervical cancer due to some other risk factor. Next slide, please. This is the total number of patients seen in the GYN oncology clinic from April 2013 until April 2023. Specifically, we do our abnormal colposcopy clinic or Pap smear evaluation center once a week on Mondays. And we've had over that period of time 10,561 visits, of whom 413 patients specifically say that their primary language is Spanish, and 617 patients registered that their primary language is other than English, but also not Spanish. On the left, you can see the number of visits total in the clinic. So you can also understand that about half of our work is focused on these colposcopy patients. Of note, Nancy Pena also works to help us navigate the patients with new diagnoses of cancer, et cetera. So her work is not limited to just the colpo patients, but that's what we're going to focus on today. Next slide, please. So what are the barriers most common that Hispanic women in the United States encounter? First, they may not speak the language. Second, they may experience discrimination, either because they are an immigrant or because their primary language may not be English. They may not have health insurance. They may have to travel long distances to the centers that have colposcopy. And they may not know what resources are available or even how to navigate the American healthcare system, which is complicated for all patients. Next slide, please. So I'd like to go through what we've done. In 2005, we implemented patient navigation in our GYN oncology clinic. We started initially with only patients being seen in our abnormal Pap center and only with patients that were seen in our clinic, which was our Monday. There are additional patients that were having abnormal Paps and HPVs on other days, but we focused mostly on our Monday clinic because that's where we see most of the at-risk patients. The first thing we looked at was initially there was roughly 50% or actually 47% no-show rate. In other words, we would make appointments for patients and they would literally not come to their appointments. After an intervention where we started with Nancy Pena calling all the no-show patients, that rate went down to 29%. And now through additional interventions that I'll talk about in a few minutes, we are down to about a 10% no-show rate, which is a significant improvement from the 47%. And we have published on this. Next, we worked on increasing the education that we provide both to patients and to providers, actually, but focusing specifically on the patients. We started using cervical cancer education with initially iPads, and now we have a whole set of resources that the patient can actually access on her phone, that are educations about HPV vaccination, education about what is HPV, education about primary HPV testing. All of these are types of education that we have now introduced. In addition, Nancy meets with every patient and educates them as well and answers very specific questions. She also feeds back to me and the clinic staff specific questions that patients have that we may not be anticipating because we may not have understood where they're coming from. One example that Nancy might share with you is that some patients were concerned that this is a sexually transmitted disease and therefore concerned how their partners would feel about this. And so Nancy started a process of educating partners as well as patients so that everybody would understand that our interventions were based on cancer prevention and why this would be beneficial for everybody. We then looked at more opportunities for reducing barriers, and Nancy will talk more about the ways in which she's able to provide resources for patients. But we have put together, I shouldn't say we, Nancy has put together a patient navigator toolkit, which is essentially a list of many different tools that a patient navigator in another clinic can use to help patients be seen. And it includes everything from very functional resources like how to get to the clinic or resources for support in those ways, to education and information about exactly what will happen at the clinic, what is an abnormal pap, etc. And one of the most important things that we have done in our clinic is that it's a mutually educational environment. So the patients teach Nancy, Nancy teaches us. We all brainstorm then anytime we learn of a barrier that a patient may have, we brainstorm what can we do differently, what can we do better, what have we not understood. And then with Nancy's brilliant brainstorming and implementation, we then continue to improve what resources we provide and how we think about care. Next slide, please. So this is a very complicated slide. And that's really important that you visualize how complicated it is. This is the process of a patient who has an abnormal pap test all the way at the left upper, coming in through care, all the different things that have to happen, all the different places where something can go wrong, and what we do in those cases. So this is a map of sort of what we do in our clinic. But I want to pause for a minute and imagine this from the other side. You're a new patient to our clinic, perhaps to our country, maybe don't speak English. And each of these buttons in this map is also something that you have to negotiate as new to our healthcare system. And you can imagine why there are so many opportunities to lose patients, and why having somebody who basically helps the patient from the moment of an abnormal test all the way through the process can be helpful. So for example, the patient has an abnormal test. The first thing that has to happen is the provider gets notified, whoever did the test, and that person has to know what it means, and they have to know what they have to do, which is to refer the patient for colposcopy. The provider also has to educate the patient, and that's not even on this slide. So the provider has to have the right information in order to be able to explain to the patient, do you need to go to this clinic? What are they going to do? Why is this important? So the provider one of the improvements we've made is that we've created an easy button in our computer that if the patient needs colposcopy, that gets scheduled. Our team then knows to contact the patient to schedule the visit, but we also do a preliminary SDOH, which stands for Social Determinants of Health Screening. Specifically, Nancy has trained our new patient coordinator to, in addition to scheduling the food, ask them, do they have any problems with food, transportation, or childcare, or any major issues that would prevent them from coming in? If they do have one of those problems, they're referred to Nancy even before the visit in order to basically see if Nancy can help them get into that first visit. At the same time, the nurse to the right is also figuring out what abnormal results have they had most recently and in the past? Do they have other severe medical problems? Do they actually need to be seen in our clinic? So even though a doctor or nurse may have referred them to our clinic, sometimes these patients don't really need to come to the colposcopy clinic. And so a nurse is simultaneously figuring out, do they really need to come? Once we determine they need to come, the patient's been educated about what they need, and we bring them in. We make sure that it's noted in their chart that there may be some concerns about social determinants of health, which is the way we use the word we use for barriers to care. And as I noted below, the patient will, our team will contact Nancy to make sure she's involved in the visit. And next, the patients will get a call from a nurse a few days before to confirm everything. And our front desk staff will call. Those are two additional interventions we've done to make sure patients come to the appointment. And then they come to the first person visit. And part of the process is for the medical assistants to ask the patients if they have any specific questions for the doctor. And Nancy, the patient navigator PN, will also see the patient and make sure that she understands if there are any major concerns. And then, based on the visit, there are results, and those results need again to be communicated to the patient. We try to send results in multiple languages, and the front desk then schedules a new appointment for them, and that's confirmed with the patient, and there's then a process for following up. At this point, I'd like to turn the conversation over to Nancy Pena, who will present the rest of the slides. I really apologize, but I am giving a simultaneous presentation at the same time in Baltimore today, so I'm not going to be able to answer any questions, but Nancy and I have worked very closely and she will answer any questions. Thank you so much for including me in this conference.
Thank you so much, Dr. Feldman. It's a pleasure to have you here in MPI in the first Pressure Navigation Congress in Latin America. So I'm going to continue the presentation and I'm going to continue in Spanish. Buenos días, mi nombre es Nancy Peña.
Good morning, my name is Nancy Peña, and I work like lead patient navigator at Dana-Farber Brigham and Women Cancer Center. And also, I am the director and founder of NPI International. Today, I have the pleasure of sharing with you this platform with Dr. Foreman, who is our director of our clinic, colposcopy clinic in gynecology and oncology and Brigham and Women's, with which we have developed a number of protocols for us and our equipment to reduce the barriers that affect our community or Hispanic communities when they come to the United States. This was designed to help also to indigenous communities and Hispanic communities in the United States to see what similitudes we have, even though if we are in different countries and different systems. Today, it's also important that we need to mention that we have champion doctors, Dr. Foreman, the things work better. Also, on another pillar that we have, MPI, is to have more doctors, because more champion doctors. When the doctors understand the program and understand that we could do a lot of things to support these patients. I would like to thank the doctor for this support. Also, we would like to comment, like Dr. Freeman, in some moment yesterday, that only to have access to a biopsy or abnormal biopsy is not enough to save the patient's life. So we speak about screening tests or um, um, only to have this, and that does not guarantee that the patient could continue the treatment or that we could save his life. We're going to speak about a little bit about our program in Boston, and I would show you this graphic that regarding COVID and how COVID affected patients during the pandemic. We could see that Hispanics in the United States were the biggest group that was affected during. And on the left-hand side, we have some cities that, for example, Chelsea, Brockton, Lawrence, Everett, and Lynn is where we have the most amount of of Hispanics, and that is where we have seen more problems, not only COVID, but of other type of economical problems or also educational and health. So this graphic also helps us understand how the Hispanic communities and other minorities are being affected here in the United States in different forms. Right after that, um, like the doctor said, I just present the slide regarding the flow and how we work with patients and how many people are involved in this. This slide also brings up that flow or that map that she showed you. This is something more easy, more simple, and that navigation do not only um, starts not only with the first, it goes by reception, coordinating the appointments, nurses, our doctors, the surgery coordinator, and navigator. When we have a patient, the patient goes through all these groups, but this group, as you know, also start asking if the patient has any barrier during the time that the patient has to come to the appointment. When he comes to the front desk, the person of the front desk could ask if the patient has some barrier, or if we're speaking with nurses, if the nursing has the same question. Probably it's not the same barrier. Sometimes we have barriers that are emotional. We have we have stigmas, we have fear, and all those fears, we start analyzing them, and we start seeing how we could have a a better approach or a better solution to help to tear down that barrier that the patient has at that moment, and that he can continue with his treatment, but especially that he has the education that he needs in the time that he needs it, like that when he gets out of the clinic, he won't be leave the clinic with fear or frustrated, that he has all his questions answered, and that he understands why he needs to come back to our clinic if it's necessary, and why that he needs treatment. The doctor also was speaking about the barriers that the Hispanic communities have in general in the United States. I'm going to talk a little about the barriers that the patient have in our community. One is education. They say, I do not understand why I have to come so many times to this clinic. The reason is, obviously, when we have abnormal Papa Nicolau, you could have 3 times, and that is up to 3 times a year. And that's something that I educate my patients, that this is the first time, but probably we could have a relationship of patients that you need to come. You forget you're forgetting appointments. It's very easy to forget. Our Hispanic communities, they have up to 3 jobs, and sometimes how could they not forget their appointments? Or sometimes also they have sick children or family members that are sick, and sometimes the health insurance problem. So probably the person has switched jobs or does not have a job, and probably at that time they do not have medical insurance, and they forget about they forget the appointment because they cannot pay for it. Fear and anxiety, this is something that all our patients, probably 99.9%, have when they come here. And as we understand this, obviously we anticipate this barrier, and we ask, how is your level of anxiety, before they could see the doctor. And then the patient explains that his level of anxiety is too high. We try to help them out with breathing exercises, and sometimes I'm even with them during the appointment. And sometimes we what's the ice cream that they like, or where they're going on vacations, to keep them distracted. um, and then we our clinic offers certain flexibility for the people to come. And transportation, we also have a number of transportation services that sometimes the patients qualifies, sometimes they do not qualify, and when they do not qualify, we need to be creative. Like, for example, we say that if a family member could bring them. Also, as I have been repeating, there is some legal resources or resources that are complete. Sometimes we have to give orient the patient to where they can need to take English classes, or if they're having a domestic violence problem, we also help them out. We have created a few protocols in our clinic regarding medications. These are some cards, and we work with the doctors and some other nonprofit organizations in Boston where these cards, and we put them at a website, and you're going to have them to in Spanish on the website. And we have utilized it with Dr. Eric Estrada in the hospital San Juan de Dios regarding medication regarding cervical cancer. These cards are 12. We have 12 questions that are HPV and what is BPH, and like that we work what is the importance of the vaccine and how BPH affects. um, we did this with 119 patients, and some of them, or probably six patient that these are related to breast cancer. And then when we learned this cancer patient, we brought up this figure where it explains exactly where the HPV affects in the body. Like that, we should educate that HPV is not related to breast cancer. We're going to give an example of a couple of patients that we have in the clinic. Actually, this patient, we're working with them right now. This patient came in January, 38 patient, Haitian patient refugee, that when he gets to the clinic after having a baby, after we saw that she had high risk of CA cervix. He's been here for 6 months in the country. He just had a baby, but she has no other resources. She does not understand the system, does not speak English, and she does not understand why she needs to come back to this clinic or why she needs to start in oncology. When this patient was over 15 calls with an interpreter to explain to her why she needs to come to the clinic and explain that she needs to follow the procedures that the nurses have already explained to her. And also, when she finally understood why she needed to come, then we need to offer her Uber. She does not have a phone, and then then I had to use my phone and use the Uber and tell the husband to get on the car with the this plate that this car could be coming to the hospital. Like that, the husband did not understand wrongly, and that she was seeing, especially if the driver is a male. So that like that, the husband helped. I wait for the patient at the lobby because the patient is big and it's a little bit intimidating. From the lobby, I take her to the clinic. There we have the interpreter waiting, and then she will have the procedure. Then I go back with her to the lobby. I use again my phone to get the Uber. So there we could see that paying an Uber that probably cost $22, probably 15 calls, we were saving the patient, the life of this patient. Because if we would not had this, and we did not have if we did not use these 15, or we wouldn't have the spirit to pick up the patient and to make him understand that why he needs to come, probably this patient would not come to the appointment. She did not want to get involved with us, and in 1 year or two, probably this woman would be dying of CA cervix. Example B. This example is very, it was something that touched me personally, because when I say that the patient was from Guatemala, and I'm from Guatemala, when I heard that I heard a patient that was 65 years from Guatemala, with very advanced stages, and that she does not have enough support of the family here in the United States. When I see that it's a person from my country, I was involved like any other case, but at this moment, this case was very complex. The patient got here with an advance, almost terminal, to the clinic. And when we're speaking about palliative care and the type of palliative care, and we tell the family, your mom is very sick, we're going to give her palliative care. But when we explain palliative care, they were speaking, and then the family was waiting that the patient is going to get better and that she was going to go back to her normal, when I understand that they did not want to make any decision because she's in palliative care, and that she understand that she's going to get better probably in 3 months. I go back to the team, to the medical team. The patient educate us, and we educate the medical team, and then the medical team comes back, and we all educate each other. And this is like a constant education. And probably in this time, I spoke with the palliative care team and tell them that they were not understanding the concept when the plane comes back, that the patient only 3 months. The patient was getting ready for this patient, and that's why the patient is in palliative care. So then we put them in the urgency of what were the patients. The patient wanted to go back to Guatemala to die in Guatemala, but the husband did not want. The husband, I believe that he was um, from the West, and he did not want to go with her because he does not have where to live to take care of her in Jalapa. That is an area. And here, what I had also, the husband that had fear, stress, frustrated, sad, because how I'm going to take care of this woman if all these women, I only have 6 women and nobody has taken care of us. And that was his place. I do not know how to take care of her. And at the end of the day, a couple of days, had to go back to Guatemala. We were able to, I had to navigate with the airline because this was a severe case, and sometimes patients do not want to airlines. We needed to get oxygen, we needed to get a lot of things that she needed to have with her in the plane for her to be able to travel. And those were some cases that we wanted to share with you, that how our navigation works in Boston, in our clinic at Brigham and Women's. As you could see in this graphic, um, the circle that we were talking about, of how the patient goes through all these medical teams, and how we start seeing all these barriers, and how we start solving these, tearing down these barriers, while the patient ends and gets the results independently of what is the end. It could be that we could prevent cancer on time, but sometimes it's that the patient comes in with an advanced cancer that has never received treatment from our countries, like we say. And here to end, we can only tell you that we have these points that we that we needed to through all the program, and we need to ensure that they have follow up for to avoid cervical cancer. Also, the changes are that the changes need to be accepted by the medical team. There is doctors and nurses and that are resisting to work in conjunction with the navigator or other components of the clinical or non-clinical component. That resistance is going to affect the patients and also the team. Regularly, when with patient navigation started in the United States, some of the resistance that we could see was that there was doctors that they were resisting, and there was also social workers and nurses. I imagine that probably in your workplaces you're seeing that, or you have seen it. So because of this, it's very important today that we to clarify that that so if I can facilitate that the patient could have his results on time, also I can facilitate that they do the appointments. I do not do the appointments, but I do facilitate that this is taken care of, and that we get it in a time where the patient can come. And also we need to measure the results. The data is important. And also the medical team, the Dr. Feldman is a champion doctor, and for her to owe that we owe that this program has evolutionated the way that it goes, especially because she's a director and because she has interest in support these patients. And sometimes some lessons that we have learned that basically that are similar, that basically of what I have already showed, and that are based in the system. And to optimize these changes, it's important that the medical team, like the patient, get involved. Like that, we could learn from them, and we could keep on going, and also create and distribute um, uh, educational materials that the patient could understand. And if they understand by figures, we will do by figures. Also, trying to eliminate barriers, especially when we have spoken about MPI. We are training people in Latin America. Obviously, they do not have the resources that we have here in Boston, but we could be creative and see how we could give get these resources for them, and also the creation of tools. And we could share these tools with you. Right now, they're in English. We're translating them to Spanish, but once we have it in Spanish, we will have it. We could give it to all of you. That is on the notes, and this is part of our team in the clinic. We have here the assistant medical MAs, doctors, nurses, and this is the team that belongs to our team in Boston. So I'm going to say here, if you have any questions, because the doctor right now has to go to another conference in Baltimore. So